Hello everyone, this is Dr. Pruett. Welcome back to this week's EKG. We've got a good one for you this week. Our case is very interesting. You get called to the airport. There's a man who experienced a cardiac arrest on an airplane and you're waiting for the flight to arrive. He's a 66-year-old male. He's got a history of high blood pressure and known coronary artery disease. Had a witnessed arrest on the plane. They used the AED. He had bystander CPR and the AED advised to shock, and they did. And so when you get there and you meet your patient, he's actually awake and talking to you, but he's very pale, diaphoretic, looks ill, and you need to get going. And so this is technically a post-ROSC patient, right? And so I always like to remind people, when you get a ROSC, just slow down. Kind of gather yourself. These are inherently unstable patients, and so you want to have everything ready to go and anticipate needing to do more things quickly. So you want to initially start with a set of vital signs, figure out your blood pressure. Do you need to start a pressor? Get the pads on, keep the pads on. What kind of medications you have to have ready, and then get a 12 lead is going to be one of your early actions that you need to do. So we get a set of vitals on this guy. Heart rate's 95. His blood pressure looks okay at 122/86, which is nice. Satting 94 on 2 liters by nasal cannula. His sugar is 160, and then you get this 12 lead. So I'm going to let you take a look at it for a second, see what you think, see what sticks out in your mind, and then we'll go through it together. And so just like always, I know there's some things that kind of catch your eye in here, but we're going to start the same way every time so we don't miss any subtleties. We have a heart rate of 105 according to the computer, and so we want to just confirm that with our eyes. I see a QRS that matches up with a thick red line here, so 300, 150, 100. He's right around 100. I'd agree with the computer. I think that's correct. We'll give him a heart rate of 105, a little tachycardic. Next, we're looking at our rhythm. Is it sinus? Is it regular? We're looking for P waves before every QRS. I do see P waves in lead 2. As we march out to different leads, I see a P wave here. Each beat, I can pretty much see a P wave. As we move across the precordium, they look good. So I will call this a sinus rhythm. Very regular. No issues there that I can see with our rhythm at all. We move on to our axis. We look at leads 1 and leads AVF, just like always. Our left thumb for lead 1 is up. AVF, I would call the majority of this down. So we have left axis deviation with our left thumb in the air. And then our intervals, we look at QRS. 108, that's less than 120, we're good with our QRS. We look at our QTC, 438, that's less than 450, not concerned about the QT, those are very reassuring. And then lastly, we move to our ST segments. I still do this the same way every time so I don't miss anything. Starting with the inferior leads, kind of looking at the inferior and the right side of the heart. Oh goodness, I see ST depression here. See how the T wave is kind of inverted and sunken below the baseline there? I'm going to look and see if I see that anywhere else. That has my eye, right? Hard to tell here because there's some artifact and maybe not as concerning in lead 3 as it is in lead 2, but lead 2 is very concerning there. AVF, I also think I see subtle depressions here. The baseline is right by that PQRS here, and it is below the baseline, maybe by a millimeter, so that catches my eye. Next, I move to 1 and AVL. These are our high lateral leads. See what's going on there. That's where, whenever I see inferior changes in 2-3 AVF, I look at the high laterals next. Oh my goodness, again, we have ST depression below the baseline here. Okay, now I'm looking for elevation somewhere, right? But I'm going to continue moving in my normal pattern as we move across the lateral side of the heart. Oh my, I still see depressions along the high lateral leads and into the anterior portions of the heart. There's depressions everywhere. Maybe not so much in these septal leads. I don't see any inversions. I don't necessarily see elevation until I get to V1. And then the lead we really tend to ignore a lot of the time, but can be very important, is aVR. Same thing here. This is massive ST elevation here. Do you see it? It's starting to look like a tombstone there. And we rarely see this, but it's one you need to know, because if you notice, we see elevation here that's greater than 1 millimeter in AVR, and we see diffuse depressions everywhere else. This is a huge red flag, and it's one you need to know because the computer is not going to help you here. This person has really bad coronary artery disease, just had a cardiac arrest, and he's got a very concerning EKG, and the computer's not really going to send any signals your way that you need to be worried about this guy. So we do see it, as we're interpreting this, I'll call this greater than 1 millimeter of ST elevation in AVR, also elevation in V1 with diffuse depressions everywhere else. This is a very concerning, very classic finding for left main artery disease, and we'll talk about that in a second. But at the end of the day, as we put this together, we've got a sinus tachycardia with a rate of 105, we've got a leftward axis, and elevation in AVR. Now, what does AVR show us? If you look at where AVR is located on the chest, our leads 2, 3 AVF, we're usually kind of looking at the right side, remember, our inferior portion of the heart. 1, 2, V1 through V4, kind of looking at that septal area as we move to the anterior portion of the heart, and then around to the high lateral leads with 1 in AVL. That's what our leads are looking at. Well, if you look at AVR, it's over here all by itself, and it's got kind of the rear view mirror there. It's looking at the back and the high right side of the heart. So it's got a perspective that's very important as opposed to all of the other leads. And what it's telling us is that right here, as those arteries come off of the aorta, you've got your right coronary artery and your left coronary artery. It's looking right there at that, and it's telling you have a big problem right here before it bifurcates into the left anterior descending or the left circumflex. So AVR, a good wave AVR, just to remind you because we don't look at it that often, everything should be down because it's backwards, right? It's reverse. So you have an inverted P wave, you have a downward sloping QRS, and you have an inverted T wave. That's normal in AVR. That's what a good AVR should look like. So if we look at our 12 lead again, that is not what we have here, right? We have the downward P wave, which is good, but we have this ST elevation, which is not normal. Here. So that is why it doesn't look normal. AVR, just a plug, we've done a whole teaching on AVR before and why it's clinically useful. There's 5 other reasons. Our big one today is left main coronary artery disease, but there's other reasons we could talk about later as well. Just don't have time today. Our guy, he ended up doing great. He was discharged home 3 days later, but I want you to see how sick this guy was. If we look at our heart again, our AVR is telling us we probably have left main disease, right? And so we're looking at this left main artery before it bifurcates into the left anterior descending or the left circumflex. This is what we see when he's in the cath lab. They have the ability to put dye in these arteries and actually see where the lesion is. And so here's his left main, and you can see there's a big defect in filling right here. He probably is very lucky because he's had a heart attack before. He probably has some filling from the right side that's called collateral circulation that's still able to fill his left anterior descending. But he's got 3 big lesions here. The left main artery is not filling really great there, even though you can see some distal flow. The left anterior descending is very narrowed here. You can see how it's narrow. And then actually the circumflex, look how there's good dye here, but then there's very little getting through on the other side of his heart. And so this is a very concerning finding. They were able to put stents in, and we know he's got a sick heart and probably some collateral circulation because you see these circles here. These are the wires from his old heart surgery, and these little black things on here are probably some sutures that were left over from that surgery. But after they were able to open these arteries with their stents, you can see he's got really great blood flow going to the left side of his heart, better blood flow in the circumflex. They kind of cut off the left main occlusion here, but you can see they restored blood flow. And so this guy was very lucky. We caught his disease, they were able to intervene, and he was able to go home. And that is all for today. I hope you have a new respect for lead AVR, and looking forward to being with you next week.